But what I want to do is just 4 cases, that's it. And 3 of the cases are designed to kind of outline a point with metabolic bone disease, thyroid, and diabetes. But the 4th case is something to introduce you to a new concept. And it's going to be kind of interesting to end the conference on this new concept. It's something that's coming down the line in terms of managing diabetes that's really exciting and I think is going to open up a lot of doors for us in the future. But I'm going to start first with diabetes. I'm going to end with diabetes, and kind of an interesting case that all of these cases are cases I've seen in the last few years, and one I saw just a few months ago. And this is one you all have been experienced with, 66-year-old fellow with type 2 diabetes for many, many years. He had been on oral agents for many years. His primary care doc wasn't getting anywhere, so they switched him over to 75-25 and NPH Lispro mix. He was up to 150 units a day. He was gaining weight. His glucoses were high. Insulin was eventually abandoned. He saw an endocrinologist, put him on multiple other medications, glimepiride, lotepile, sitagliptin, the DPP-4 inhibitor, all in maximum doses, no insulin. Patient was gaining weight and his A1C was lousy. How many of you have seen this over and over and over again? Exactly, it's so common. At this point, glargine was added. His A1C still didn't improve. All he did was get fatter. He wasn't paying much attention to his weight. As with many of these folks, they get frustrated. He quit monitoring his blood sugar because it always said the same thing anyway, and he wasn't getting anywhere. He couldn't take metformin because previously he had had renal issues. He kind of exercised on again, off again, not an awful lot. He was one of these fellows who comes home and kind of grazes all night long. He wasn't paying any attention to his diet, bored of eating more than anything else. He had had no microvascular complications, no evidence of neuropathy, but he did have coronary disease, and a relatively younger fellow, cabbage in '96 and subsequent stenting. Of course, with the diabetes came his hypertension. He also had that, hyperlipidemia, sleep apnea, medically complicated obesity. I'll show you his weight here in a minute. So this is pretty common bread and butter, type 2 diabetes mellitus. And when we saw him, here's what he was taking. Just a phenomenal gamish of medications. As I mentioned, once you get a diabetic on 3 or more oral agents, you've got a confused patient, and it generally doesn't work. And that was what was happening with this fella. Social history, non-contributory. You can see here his weight. His BMI was 43, so this guy was morbidly obese. Blood pressure was kind of right on the border. Here were his labs when we saw him. In spite of the fact that he was on the statin and the gemfibrozil, his LDL was not at goal. A goal in this fellow would be an LDL of closer to 70. So kind of here we are in a summary, and pick your diabetic patient that you see every day. You're going to find much the same sort of story. A fellow who's frustrated, gaining weight, and is failing to thrive. What are you going to do for this fellow? What are you going to put him on? Any ideas? And this is what we did. We stopped the pile on him because it does cause edema. He was noticing problems with edema, and it does cause weight gain. And this is almost universal with pile, Rosie. Both of these do the same thing. And for the most part, the TZDs, I think, are falling by the wayside, in part because of the side effect profile. I personally haven't found them to be all that effective. They will lower A1C in the right patient, but for the most part, the TZDs haven't really panned out. In theory, they're the perfect drug, but we're still looking for the perfect TZD. We stopped the DPP-4 inhibitor. We kept him on the glargine to look after nocturnal, nighttime glucose, and we kept him on the glimepiride for his meals. But here's one where we added the exenatide. It's approved with the sulfonylurea when we first gave it to him. It is now approved for treatment with insulin as well. So we put him on exenatide. Now again, I'll go back to that slide that I had for you when I covered the diabetes issue with the GLP-1. What it does a number of different things. Reduces the appetite, delays gastric emptying. That subsequently tells the brain that you feel full. It does affect the pancreas to increase insulin in a glucose-dependent fashion. It enhances insulin sensitivity, and it helps lower glucose production level of the liver. And as I mentioned earlier, there is some suggestion that it also has some cardiac effects which are very beneficial, and that currently is being studied. In patients with exenatide, there is weight loss that we've documented, and it can be several kilograms. But what's interesting with this drug is the bigger you are, the more effective it is in terms of losing weight. And many folks will lose 10 to 15 kilograms in weight, which is a pretty substantial weight loss. Bear in mind that in most type 2s, it does not take much weight loss to change glucose dynamics. As little as a few kilograms. In some patients that aren't morbidly obese, 10 or 15 pounds is all it takes to improve glucose dynamics in these folks. But the higher the BMI, the more weight loss we tend to see in patients with an exenatide, and this also holds with liraglutide or Victoza as well. But we do this in conjunction with behavior modification in terms of classes, dietitians following along with the patient. It is important that we get some behavior modification on top of this. And studies would indicate that addition of exenatide to insulin, you can lower the A1C by perhaps 1.5 to 2 percentage points, which is a pretty big drop for just one medication. There are some concerns about this drug that I didn't go into in great detail when I was talking about it. Pancreatitis. We're starting to see a little bit more pancreatitis than we want to see with this medication, so if there's an old history of pancreatitis or pancreas problems, probably wise to avoid it. This is on the radar screen in the FDA. We're looking at it pretty carefully. You want to avoid it in patients with chronic kidney disease, particularly if the creatinine clearance is low, because it may tend to make this worse. The major symptoms we get are nausea, diarrhea, vomiting, constipation. This is why we start at a low dose, 5 micrograms once or twice a day, step it up to full dose after a month, which is 10 micrograms twice a day. Liraglutide, you can start at 0.6 milligrams. It's only taken once a day, and then step that up to 1.2 or even 1.8 after a month or two if they're tolerating it well. It is a nuisance. It needs to be taken by injection, and as I showed you in one of my earlier slides, it's also very expensive. Is it better or worse? That's up to you and the patient to decide, but it is expensive and it is a nuisance. But you know what? It is effective, because look at what happened with this patient. Follow-up of him after being on this stuff for 6 months, the glimepiride and the Lantus only, he had lost 45 pounds in weight, and his A1C is at goal, 6.6%. And now he's checking himself. He's paying more attention to the diet because he's feeling better, he's seeing positive response, and he's a lot happier camper. This isn't an isolated case. I've seen this fairly frequently in type 2s who are on big doses of insulin, who are obese, who just can't get it under wraps. If you add in the GLP-1 analog, either one of the two of them, we've had some pretty good success with it. So I put it out there as a potential, and it works well. In this case, actually very nicely demonstrates that. I'm going to leave questions, I think, for the end, because I'm going to kind of cover, I'm starting with diabetes, I'm going to end with diabetes, but we should have lots of time for questions at the end. But I toss it out as an interesting concept in a patient that actually did really well. Shift over to bones, and I want to make a point here. I've been talking about bone densities as the bone density used to diagnose osteoporosis, but you know that all that is thin is not necessarily osteoporosis. A bone density simply tells you that that bone is thin. It does not give you a diagnosis, a pathologic diagnosis. And other things can lead to low bone density, as I'm going to show you with the next case, which was really an enlightening and interesting case. This was a 70-year-old lady who in 1997, I think I saw her originally, oh gosh, 3 or 4 years ago now. She sneezed and blew 4 vertebrae. She had no prior bone problems before that. She simply sneezed in the late 90s and broke vertebrae. It was recommended that she start a Fosamax, but she politely and firmly declined. And that was the end of it until 2005, and she was doing some minor housework, again developed pain in the back area and pain quite consistent with fractures. Now her history was at age 50, she underwent menopause. She had not been on estrogen in the past. She was otherwise a very well lady, no drug history. Her weight over time had been slowly going up as she'd gone through menopause. She had no GI symptoms. She was, however, a heavy smoker and continued to smoke. Family history was negative. Now, in 1997, the x-ray showed T12 fracture and rib fractures, but by 2005, she was fractured all the way from T6 to L4. Every single one of them had collapsed to variable degrees, and that was consistent with the history that she had given us, with this history through the years of the back pain. And as you can see, her bone density was a tad on the low side. So she had problems. She had multiple fractures. She had actually one of the lowest bone densities I've ever seen. With the history that I put forward to you, no other meds, no other risk factors, no steroids, nothing else other than what you see here. Her routine studies, liver, kidney function, SPEP, TSH, all were normal, but her bone alk phos was very high, consistent with probably prior fractures or other issues, and her calcium was way down at the lower limits of normal. Her PTH was elevated. Her 25-hydroxy vitamin D was very low, less than 6, and her urine calcium was extremely low at 13. So because of this, we went on and pursued further, and I got some antibody studies on her, and her endomycel and transglutaminase were both elevated, and subsequent EGD showed SPRU. And it was absolutely classic for SPRU. This lady did not have osteoporosis. What she had was osteomalacia, which is a different bone condition. Osteoporosis, the bone that's there is usually normal, there just isn't much of it there. It's kind of like a soda cracker. You can't bend an osteoporotic bone. Osteomalacia is a failure to mineralize bone osteoid that is already there. So we're not getting calcium into the osteoid that's already set up, and it's kind of like a piece of bread. It bends, and if you bend it enough, sooner or later it will break. But osteomalacia is a different condition. They both have low bone density. They're both entirely different diseases, and they're treated entirely differently. So when you're seeing that bone density, bear in mind, could there be something else? She had osteomalacia because of abnormal vitamin D dynamics, and I have a few words here about D. It came up in the question period the other day. When you look at what can affect vitamin D, by far the most common cause of abnormal vitamin D levels is dietary or sunlight insufficiency. That is number one. Intestinal malabsorption, SPRU, Whipple's, surgical short gut. If there's pancreatic insufficiency, you need, if the D is a fat-soluble vitamin, you need to be able to absorb fat. If the liver is not working properly, you're not going to convert vitamin D to 25-hydroxy. There are some rarities involving vitamin D-resistant rickets, and some drugs will interfere with vitamin D, but the more common causes of low vitamin D are up there, and this is what this lady had. Biopsy-proven SPRU, and she was completely asymptomatic. If anything, her weight had gone up a little bit over time, but no GI symptoms. This is where she fell. Now, how common is vitamin D deficiency? I want to kind of verge into this area a little bit. I had mentioned it earlier, and this was a study that was done and published in one of our endocrine journals a few years ago, showing it's very common. If you take a vitamin D level of less than 30, a 25-hydroxy vitamin D, I'm referring to here. Where's my pointer? Yeah, there it is. Of less than 30, over half of postmenopausal women in this country are going to have vitamin D insufficiency. And if you set the level at less than 20, which is pretty profound, that's getting down there, vitamin D insufficiency. 1 in 5 menopausal women are going to have a low 25-hydroxy vitamin D. Now, this is not women who are living in Boston and Seattle and Minneapolis. This is women around the country, so it's not unique to the northern latitudes, although it's more common in the northern latitudes. And you would think, well, gosh, maybe we should all move to Florida, and we're going to get enough vitamin D if we do that. But we've looked at vitamin D insufficiency in Florida, and again, it's been published in one of our endocrine journals. In the wintertime, with 40% of individuals in Florida are going to have vitamin D levels less than 20. Now, how can that be? You're living down in Florida in the wintertime, and maybe they're indoors all the time, or they're putting on their sunscreen and they're not going outside or whatever. But 10% of them are going to have a profound vitamin D deficiency. This is in the wintertime. What happens in the summertime? Much the same sort of thing. 1 in 4 individuals in South Florida in the summertime has vitamin D level less than 20. That's pretty profound. I can show you the same statistics for Arizona. That's been published for Arizona. And I'm sure if we went down to Australia, you could find the same sorts of numbers. So if you buy into this concept that vitamin D deficiency is an issue and probably needs to be treated, it is out there. It is common, and you're going to see a lot of it. That doesn't mean that treatment is going to help. We're still doing those studies to look at that very issue, but vitamin D insufficiency is a really, really big problem in this country, and it's a problem around the world. If you look at here worldwide studies of 25-hydroxy vitamin D of less than 10, now we're talking really profound D deficiency. You can see the percentage of people in various countries around the world who have this, particularly common in South Europe and Central Europe. I don't know if there's too much smog over there, or they just never go outside, but it's a very common problem here. It's common around the world. Does that mean that if we fix it, we're going to have a world full of healthier people? I don't know. We're still working on that one. But vitamin D deficiency is really, really common. And when you look at Our Lady, you can see what some of the problems are. You need D to mineralize bone. D, calcium, and phosphorus work together to get mineral onto that osteoid. Now, how common is SPRU in patients, or how commonly do we see SPRU? How commonly do we see osteoporosis? There's some interesting GI studies that have been put out. Estimated 10 million patients with osteoporosis, another 18 million with osteopenia, mainly in females. Celiac disease is also very common. It's mainly in females as well, and 10% of celiac disease patients present with classic symptoms. 90% of those patients are going to be asymptomatic, just as that patient was that I showed you. The bone density is reduced in patients with SPRU due to the abnormal calcium and vitamin D. They're not getting D in, they're not absorbing calcium. PTH levels go up. When PTH levels go up, that stimulates bone turnover over time. If the D deficiency is profound enough, the calcium doesn't get in because it's not being absorbed, and you're going to end up with your osteomalacia. And in fact, probably 1/3 of your patients with SPRU are going to have thin bones, and this can be the initial manifestation of presentation in people with SPRU, as it was with this lady. The initial manifestation was low bone density, subsequent fractures, and her osteomalacia. Now, flipping that coin over, how common is SPRU in patients with osteoporosis? And this has been looked at over at WashU. They took 200 and some odd patients with osteoporosis and 500 and some on without. They did tissue transglutaminase and endomycel on all of them. Those that were positive were then biopsied, and this is kind of what they ended up with, was that in folks with osteoporosis, 3.5% of those people had SPRU that previously hadn't been recognized. Whereas it was very uncommon, only 0.2% in those without osteoporosis. So it was kind of a provocative recommendation that they came out with, as maybe we should be screening all folks with osteoporosis for SPRU, because 3 to 4% of them are going to have SPRU, which is a different condition. It's treated differently, and if you treat the SPRU, the bones tend to look after themselves. This hasn't been accepted in our world yet, but maybe we're heading in that direction. Is that bear in mind, SPRU can happen, and it can lead to a different condition, that being osteomalacia. In fact, this is where the endocrinologist picks up their SPRUs. We pick it up through the bone clinic. We send it down to GI. I see this maybe twice a year, unrecognized SPRU with osteomalacia, and then subsequently I leave it with the GI folks to follow up on it. Now, the diagnosis of vitamin D deficiency is unfortunately mainly in the lab. By the time they have clinical manifestations of vitamin D deficiency, the cow's out of the barn. Clinical manifestations are way down at the end point when patients are having problems. And one common problem that folks with vitamin D deficiency and osteomalacia get is bone pain. And I tell folks, docs tell patients, if you have osteoporosis, bones don't hurt. When bones hurt, you have another condition. The osteoporotic, where we get bone pain, is when they fracture. That patient doesn't know they have it until they break. But if the patient comes into the office with muscle weakness, they're kind of waddling because their bones are painful, think osteomalacia. Now, why do the bones hurt in osteomalacia? Is that you're not getting calcium in, that bone becomes soft and it bends. And when it bends, it stretches the periosteum, and that leads to bone pain. It doesn't happen with osteoporosis. The bones don't bend, they break. So if a patient comes in who's weak from vitamin D deficiency, they're kind of waddling because their bones hurt, they complain of bone pain, and their bone density is reduced, think osteomalacia. So if you get an x-ray of the pelvis and you see a so-called pseudofracture, that's pathognomonic for osteomalacia. Osteomalacia, again, is a different condition. It's treated differently. You treat with vitamin D and calcium, and Fosamax, all the Fosamax on earth isn't going to help these individuals. But the symptoms occur late in the development of the disease process. Now, a question that's frequently asked of me is how, sunlight, we know sunlight works. How effective is sunlight? And this has actually not been studied all that well. And there was an interesting article put out just a few years ago in one of our bone journals looking at the effect of sunlight in a captive audience, which was Alzheimer's patients. And essentially, these were 260 some odd patients who were chronically institutionalized with their Alzheimer's, and they split them in two and exposed half of them to sunlight, and it was only 10 minutes a day. We're not talking about 3 hours on a beach here, but 10 minutes a day in sun-exposed areas, head and neck, if the weather was warm, shorts, otherwise arms, just sitting outside for a year. And 132 were left unexposed, institutionalized inside. All received calcium and vitamin D, and then they looked at endpoints, including vitamin D levels and bone density results. And this is what they came up with. Prior to being treated, vitamin D levels in these institutionalized Alzheimer patients were very low, as you would predict, down around 10. So that's extremely low. And those patients that were sunlight deprived for the year, their vitamin D level actually went down a little bit. And those that were given 10 minutes a day, their vitamin D level went up to over 20, which is starting to get into a zone that we feel is safe and is good from the bone standpoint. So 10 minutes a day, sun-exposed areas, I can't remember the latitude where this was done, will raise vitamin D levels. And that did translate to an improvement in the bone density. Those folks that were sun-exposed, their bone density did go up. And although the numbers were very small, fracture rate was lower in those individuals who were set outside versus those that were put inside. So it was statistically significant, but the numbers are vanishingly low. I wouldn't pay much attention to the statistics on this. But I think the key or the clue was there. It doesn't take much to get to help with bones and raise your vitamin D level. So here's one where the dermatologists and the endocrinologists, who are constantly crossing swords on this issue, need to come to grips with each other. We're not saying stay out on that beach for several hours a day. We're saying 10 to 15 minutes in sun-exposed areas is probably okay, and I don't think everybody's going to die of their melanoma with that. And a lot of dermatologists will actually buy into that. Humans were not made to be inside, fully clothed at all times, so there is a role for vitamin D. But it's like everything else, it's moderation. Now, in terms of vitamin D deficiency, if you're going to treat, the current RDA is not 400. The IOM now is recommending 600 units a day. Most endocrinologists would recommend 800 to 1,000 units a day of vitamin D because there are virtually no side effects. Vitamin D can create a little bit of calcium in the urine, so if you've got kidney stones, you might want to check the urine calcium before placing that patient on larger doses of vitamin D. If they have a severe deficiency, a moderate or severe of less than 20, then 50,000 units monthly, weekly, or you can even give it twice weekly for a period of a couple of months. Will boost that level up quickly, and then you can switch them over to over-the-counter preparations. Again, if there's a history of kidney stones, caution, because vitamin D in bigger doses can cause increased calcium output. We don't need to use calcitriol or rocaltrol. It is the metabolically active form of vitamin D, but it's very expensive and for the most part isn't required unless the patient has kidney disease. 1,25 dihydroxy vitamin D, which is what's metabolically active, the 1-alpha hydroxylase lives in the kidneys. So if you have chronic kidney disease, stage 3 or 4 or more, you're not going to make 1-alpha, you're not going to make 125, and you're going to see calcium problems as a result. Giving that patient 25-hydroxy vitamin D isn't going to help because they're not going to convert it to 125. So in the chronic kidney patient, calcitriol is preferred in modest doses. This does help with bones and does help lower parathyroid levels. And we still recommend calcium supplement on the order of 1,200 to 1,500. In spite of what the Women's Health Initiative says, if there's a concern about kidney stones in an individual who has a history of stones, measure a urine calcium. If the urine calcium's up over 300 and 350 milligrams in 24 hours, you could put them on a hydrochlorothiazide. That gets calcium out of the urine and frees you up to give them calcium supplement if you choose. Maybe in the question period, I can go over the effect of hydrochlorothiazide on bone itself, but there are ways of getting around the hypercalciuria issue. So this is kind of how we go at vitamin D now. And that patient that we had was Sprue. We put her on 50,000 units of vitamin D twice a week. As I recall, she was on it 3 or 4 months. Her levels came up beautifully. Her calcium levels came up beautifully. Her parathyroid levels went down. And over time, her bones did very well indeed. With simply avoiding gluten, giving her vitamin D and calcium, she did fine over time, now that the fractures are over and done with. So that's a little bit about vitamin D. That's a common one that's raised, and hopefully at the end we'll have some time for questions there. Still got good on time. Third case is a little bit different. This was a good friend of mine at the clinic who's a great cardiologist, really nice guy, but he's wound just a little bit too tight, and I've told him this many times. But he came to me one day about a year ago complaining of palpitations, and he's a 45-year-old fellow who had noted over the last 3 or 4 months a lot of fatigue, lack of energy, exercise tolerance was reduced. This is a guy that's in the gym every day for an hour a day, so he was tuned in to exercise and what he could and couldn't do. He was noticing he was getting short of breath and had the palpitations, and himself had noticed a frequent bigeminal rhythm. He'd lost some 8 or 10 pounds, and he was already kind of a skinny guy to begin with, but his appetite, if anything, was normal to perhaps increased. He was nervous, anxious. All of this fits with hyperthyroidism. He had no eye or skin changes, and he wasn't on any medications that would do this to him. Now, here's an interesting fellow because he has a history of obstructive hypertrophic cardiomyopathy, and he can't get his pulse much over 110 anyway because he starts to faint when that happens. And when he does exercise, he occasionally uses a little beta blocker. He keeps a pretty close eye on his pulse so he doesn't get it up too high. He was on a little Zocor. Like all good cardiologists, he's really wound up with his cholesterol levels, and he used the metoprolol as needed, mainly with the exercise. Past health, pretty healthy fellow. When I saw him, his pulse was at 104, and that was at rest. And this is a guy that's in shape. His blood pressure was up a little bit, his pretibial areas were clear, his eyes were clear, his skin had a classic velvety kind of moistness that you see with hyperthyroidism. Reflexes were normal, and the thyroid itself was fine. It was normal in size, shape, and consistency. I couldn't pick up any nodules. It wasn't tender. Here was his thyroid panel. Now he ordered all this on himself before I saw them because half of what's here we didn't need. But in any event, he ordered the TSH was reduced, his total T4 was high, his free T4 was high, his free T3 was high. He checked it all. I mean, he just went through that list and checked it all off because the clinic was picking up the cost. He measured TSIs or TRAVs, depending on what lab you are, and that was less than 1, which is normal, so this tended to sway against Graves' disease. What are you going to do next on this guy? He's biochemically hyperthyroid. What test are you going to order next? And I hope the immediate answer that you all came up with was a 24-hour radioactive iodine uptake, doc. We've got to find that uptake to split to find out what it is he's got. And his uptake was extremely low. He had no reason to have a low uptake. He wasn't taking iodine. He wasn't eating a lot of kelp. He had not had any CT scans with contrast prior. His iodine pool wasn't expanded. At least at this point, he's not on amiodarone, but he had no reason to have a low uptake, but it was very low. Now, I didn't do a thyroid scan on him. That's why I put it in brackets, because I didn't need to do a scan. So when we go back to what I did for this fella is simply put him on beta blocker. I said, Steve, you need a beta blocker. We're going to leave this alone, and I'll show you why nature's going to look after itself here in just a moment. That's all I did. And now the uptake made the diagnosis here. Recall with that previous slide I showed you that there's 2 broad categories of hyperthyroidism. Endogenous thyroid production from a gland that's inherently abnormal, such as Graves', multinodular goiter, and so forth, or the leakage thyroiditis in patients with subacute thyroiditis or painless thyroiditis, where the gland is hit by something, we think it's viral in nature, and it simply leaks thyroid hormone out, and they become hyperthyroid. That condition is self-limiting. It goes away on its own if you leave it alone. The diagnosis is made with the radioactive iodine uptake, which is what the case was with this fella. Is it, Steve, leave it alone. There's no reason to have a low uptake like this. It's got to be a painless thyroiditis, and here's your beta blocker. We want to keep your pulse down, and you might want to take it easy at the gym for a while. 2 months later, he was feeling a little bit better. He's still anxious. His weight was stabilized. His palpitations were clearly better. Now things are changing. His free T4 has fallen into a mid-range of normal, but his TSH is still suppressed. And this comes back to a point I made a little earlier, that it takes time in patients with resolving hyperthyroidism for the TSH to catch up. That pituitary is a little numbed, and it takes time. You're going to see a change in the free T4 before you're going to see a change in the TSH, and this is what was happening with him. He was getting himself off the beta blockers, and clinically he was doing a lot better. 4 months after I saw him, he's completely asymptomatic, and now he's hypothyroid. Thankfully, he wasn't feeling it. He was back at the gym and doing well. His free T4 was low, and his TSH was elevated. So what did I do with him? Absolutely nothing. We sat on it because of the natural history of this, and I'm going to show you in a minute, and he did just fine. He had no symptoms of hypothyroidism, but here he was, normal at one point, hyper, now he's hypo. 6 weeks after that, I saw him back. Again, asymptomatic, and now he's normal. T4 is normal, TSH is well within normal range, and he's done fine. I think the last time I checked this was a year ago, and he's sailed through it without any further sequelae, doing fine. So what this man had was an episode of a painless thyroiditis, leaked out thyroid hormone. The natural history is such that it improves on its own, and you just hold their hand and walk through with them. But it was that uptake that made the diagnosis. That's what told me what was going on. And when you look at painless thyroiditis, and to some extent a subacute thyroiditis, the painful thyroiditis, there is a natural history, and this is what we see. Your free T4 goes up, it plateaus, it comes down, it frequently goes below the lower limit of normal, it comes up, and then it stabilizes. And the mirror image of that is the TSH. It goes down, it comes up, goes down, and then stabilizes. And all of this transpires over about 3 to 5 months. Occasionally it can be done within 2 months. Occasionally it can take 6 or 7 months before it gets better, but it does get better. 90% of folks with this condition, that's it for the rest of their lives, they do well. About 10% of people in the hypothyroid state, where's my arrow, here it is, the free T4 goes down, the TSH goes down, and it stays down, and it stays down, and it stays down. These are folks who have damaged permanently that gland. Whatever that insult was that caused the thyroiditis, and again, we think it's usually viral, it's permanent damage to the gland. And if they still have an elevated TSH and low free T4 months after the fact, then I put them on thyroid hormone because it's not going to get better. That only happens about 10% of the time. 10% of these folks will go on and develop a recurrent problem with this, where they come back a month from now, or 2 years from now, or 5 years from now, and they're going through the same thing all over again. And I have seen folks who've gone through 3 or 4 episodes of this over the years, and it does get a little tiresome for them, but they do recognize that it always gets better on its own. So that's pain with thyroiditis. It's out there. It's not common. We see a lot of thyroid, and I might see this once or twice a year, but it's certainly there, and that one test makes a diagnosis, and I love seeing it because it gets better all by itself. Well, here's just the brief comment about the overproduction versus the leakage thyroiditis. They're both hyperthyroid, but it's the uptake that tells us what's going on. Okay, and I'm going to end here and say we'll have lots of time with questions, with a new concept in terms of managing diabetes and what's coming down the line. And this was all predicated, and the reason for doing this is a result of a case that I saw and have been involved with for the last 1 year. And it really hit home to me just over this last spring. I've seen patients like this before, but I hadn't seen one this profound in terms of illustrating a concept and what's coming down the line with diabetes management in the future. And this was a 40-year-old lady who in 2004 had a positive glucose tolerance test. She was told her had diabetes. She was put on metformin. She developed gastroparesis and had stopped the metformin, so she was switched over to 70/30. She was failing that, and through the years have been on various treatment modalities, including Lantus, Novolog, Byetta. The Byetta didn't help her at all, even though she was obese, morbidly obese, and it was stopped after 6 months. And she was just left on insulin alone. And over time, until summer of 2010, her insulin needs have been progressively rising. Again, how often do you folks see this? You see it all the time. So that at one point in August of last year, she was taking almost 400 units of insulin a day just to keep her blood sugars kind of in a crummy zone of 150 to 200, and her A1C was no good. That's a lot of insulin. And she had tried everything else. She tried the Byetta route, and unfortunately it just didn't work on her. Her problem was that of obesity. She'd had a lifelong history of obesity and progressively, slowly getting worse over time. At the time we saw her, her BMI was 33. She had a lot of complications related not only to obesity, but to the diabetes, including the gastroparesis, neuropathy, early retinopathy, non-alcoholic steatohepatitis, all of this courtesy of the diabetes and the obesity. She was hypertensive. She had hyperlipidemia. Last summer when we saw her, her LDL was 123. It still wasn't near goal on maximum doses of Crestor. I mean, this is one of the few folks I've ever seen on this much Crestor, and her LDL still would not come down into goal range. Here's where it gets interesting. Because of the morbid obesity, she was a motivated lady. She was doing well. We felt she would be a good patient to do a gastric bypass procedure on. So in May of this year, she had her Roux-en-Y gastric bypass, and it went well. There was no problem at all with the surgery. It was done laparoscopically. She was out of hospital in a couple days and bounced right through the surgery itself. A day after surgery, now going into surgery, her A1C was 10.5. It was terrible. She was on 350, 400 units of insulin a day. The insulin was stopped after the surgery, and within a couple of days, she was placed on NPH, taking only a total of 16 to 20 units a day of NPH within 48 hours of having that bypass performed. Look at the date on this. 10 days later, she's off all insulin. Her blood sugar's in the 130 to 160 range. She'd lost some 10 pounds of weight, which isn't a lot, but it's clearly heading in the right direction. She had no problems with dumping, and she was put on metformin. So in 10 days, she'd gone from 400 units of insulin down to none, and she's on metformin alone. And it was just a striking case. And by August, which was 3 months later, she'd lost some 60 pounds of weight. Her blood sugar was in the low 90s. The metformin was stopped. Her A1C was 6.0, and her LDL was 78. The Crestor was stopped at that point. This was when I last saw her, was in August. She's due to come and see me again anytime soon, but she's off insulin, she's off metformin, she's off Crestor, she's doing well, her weight has come down. The only thing we did in here was bypass her. So she had a gastric bypass procedure, and at least at this point in time, her diabetes looks like it's cured. So this raises the concept of not just bariatric surgery, but metabolic surgery, is that with this surgery, we are doing something to diabetics. And we have been aware of this now for some 20 years, as I'll shortly show you, that bariatric surgery in patients makes a difference if they have diabetes. There are a number of different surgical procedures on the GI tract designed to treat, quotes, morbid obesity, but this is now becoming an option to treat type 2 diabetes mellitus in folks who have a problem with obesity, and that's why it's taking on the term now, metabolic surgery. So I'll show you that this kind of surgery, depending on the procedure that's done, often normalizes the blood sugar in these diabetics within days of the procedure and does reduce in virtually all of them the need and the amount of diabetic medication that they're taking. And there's all sorts of procedures out there. The lap band procedure, which is considered restrictive, it simply restricts the GI tract. It doesn't replumb the GI tract, it just restricts it so food can't get in. The Roux-en-Y, which is very popular in this country, biliopancreatic diversion, which is a little bit more common in Europe, is a very complicated surgical procedure, and I don't understand most of the plumbing myself. But the Roux-en-Y is very common in this country, and these are considered diversion procedures. We're actually replumbing the GI tract. Sleeve gastrectomy is another restrictive procedure where we're just limiting what the stomach can do, but there are a number of different procedures that are out there that fall under this category of metabolic surgery. Previously, they were designed to help with patients with obesity and manage their obesity, but we're sure are now aware of what this does to diabetes. And this was first described by Walter Porres, who's kind of the grandfather of this field, in 1992, when he put this paper out in one of the surgical journals describing, he's from East Carolina and still works down there and does a lot of work on this particular issue, is type 2 diabetes mellitus a surgical disease? Can we use surgery to cure these patients? And when you zero in on the abstract, again, this is 1992, they had looked at all of their morbidly obese patients who had undergone what essentially was a Roux-en-Y, and there were over 500 of them from 1980 up until 1990. And of those 500, 56% were diabetic, and they observed that after the surgery, 90% of these diabetics had their diabetes resolved. So this was the first observation that this surgery designed for morbid obesity helps diabetics. Porres has since published numerous papers about this, and a lot of papers from around the world have substantiated the effect of what these surgeries do in diabetics. And here's one of the original patients in that paper that he put out, and it's strikingly similar to the lady that I just showed you that we saw last spring. Is that if you look at the blood sugar level, oops, here we go, get that arrow. Prior to surgery, it's very high. 1 to 2 days after surgery, it's coming down very rapidly. Insulin levels have dropped considerably so that within a week after surgery, there's no insulin. Blood sugar levels are essentially normal. This is identical to that case that I just showed you, and this was out of Porres' paper in 1992. And we see this over and over and over again in morbidly obese patients who have type 2 diabetes mellitus. Now, since then, we've looked at kind of systematic analysis around the world of what these procedures are doing, and this was a big study put out in the American Journal of Medicine just a couple of years ago. Again, a meta-analysis and problems with meta-analysis, looking at percent excess weight loss, percent diabetes resolved for greater than 2 years, or the diabetes improved or resolved for greater than 2 years with various procedures, gastric banding, gastroplasty, gastric bypass, and the biliopancreatic diversion. And you can see that pretty much all of these, this thing is really sensitive today, I won't use the arrow, will result in excess weight loss. That's why these procedures were designed. They work well. But look at the percentage of diabetes that's resolved for greater than 2 years in a lot of these patients. Now, this is meta-analysis. This is looking backwards over time with several thousands of patients, so it starts to gather some statistical significance. But probably the best group to look at this whole issue is something called the Swedish obesity study. And these are a prospective controlled study looking at obese patients surgically treated versus conventional therapy and followed over many years. We're just getting the 20-year data that's coming to pass now and is going to be coming out in publication. And these are over 4,000 morbidly obese patients in Sweden, where it's a captive audience. It's like the Canadian medical system where the government's running everything. These are patients that were matched for treatment purposes to surgery, and there were various surgical procedures or conventional therapy, and we followed them, or they have been followed now over time with a very good retention rate. 75% of these folks are still on board. And as you can see here, predictably, this is the weight loss at 10 years. And hopefully, if I do this without making this thing, here we are. You can see with the various procedures, banding, gastroplasty, gastric bypass, 10 years later, there is a significant weight loss compared to control. That's why we do these procedures. But the exciting thing here was look at what happens with the diabetes, and I've highlighted that right here. Is at the end of 2 years, 72% of patients who had this surgery, their diabetes is gone. At the end of 10 years, 36% of these patients who had these procedures done, the diabetes is gone. We see the same thing with the blood pressure, is that 34% at the end of 2 years have blood pressure that's under control compared to control. At the end of 10 years, it's dropped a little bit down to 19%. And same with hyperuricemia, the same with lipid levels. Is it 2 years, 10 years, now 15 years, and shortly 20 years out, we're seeing the effect that's being maintained in these patients. But from the diabetes standpoint, this is really exciting. The 15-year data has been published and 20-year data is about to come to pass. Percent diabetes remission in these folks with morbid obesity, 72% remission at 10 years. It's fallen a bit to 36%, 72% at 2 years, fallen a bit to 36% at 10 years. But 15 years later, 30% of those folks that were previously diabetic, the diabetes is gone. Now, I throw this out as a challenge. Can you think of any other chronic disease where one intervention results in complete amelioration of that disease in 1 in 3 patients 15 years later? This is why this is so exciting, is that the concept behind this in terms of how effective this is in managing diabetics. They've also looked at prediabetes, and I haven't had a chance to go over prediabetes with you at all, but prediabetes is a stepping stone to diabetes. We know that folks with prediabetes will go on and develop diabetes at the rate of about 5% per year. And in this particular Swedish obesity study, the SOS study, getting some feedback somewhere here. There was a 75% reduction in the chance of developing diabetes after 20 years. So these are pre-diabetics. 75% of them 20 years later did not have diabetes. The very best we can do in this country, and other studies around the world have shown this, is a diabetes prevention program where we've looked at reduction with vigorous lifestyle modification, control of diet, weight loss, occasional use of metformin. The best we can do is reduce the development of diabetes by only 57% at 4 years. So here we've got surgical evidence that we can prevent diabetes from going on to developing diabetes much more effectively than any other program so far designed. And as I say, the 20-year data on the SOS is about to come out, and it's going to show much the same sort of thing.
Why the diabetes comes back, that they're gaining weight?
Yes. Yeah, the question Jan raised, that the reason the diabetes comes back, it's usually because those folks who have failed are gaining weight back. Why the diabetes goes away in these patients is unclear. There's a lot of work being done on this, but these folks within 48 hours of the surgery have lost their diabetes. That's not because of weight loss. There's something else going on in the background, and it's unclear exactly what. But Jan's right, is that the ones who get it back, it's typically those who've regained it. Now, does diabetes control in this group translate to improvement in the long term? Yes, it does. When you look at mortality in these folks, the unadjusted overall reduction in mortality overall on them is considerable and is statistically significant. When you adjust it for sex, age, other risk factors, it remains even better. So the surgery is helping the diabetes, and either surgery, the loss of weight, or the diabetes, hypertension, lipids, whatever else, these people aren't dying as much when they undergo these surgical procedures, which are now very safe and easily undertaken. The International Diabetes Federation has just published, it just came out a couple of months ago, recommendations looking at this whole metabolic surgery, bariatric surgery issue. And the IDF, it does feel that bariatric surgery is appropriate treatment for the obese, type 2 diabetic, not achieving treatment target with medical therapy, especially if they have comorbid problems, hypertension, hyperlipidemia. And it should be considered as an option in type 2 with a BMI of over 35. Should also be considered as an option in a BMI between 30 and 35 when diabetes is, again, not controlled with the optimal medical program and other major cardiovascular risk factors are present. So these are recommendations published by the IDF now, which are mainstream. And when I go back to that stepwise approach to treating diabetes that I showed you previously when we started this whole conference, this is where it would fit in. If you're failing monotherapy, consider bariatric surgery. If the BMI is over 35, we would consider them eligible for bariatric surgery. And if their BMI is over 40, we would prioritize them to getting bariatric surgery because of what this is going to do for the diabetes. If these folks are on combination therapy and they're still not at goal, with 2 or more therapies, including insulin, if the BMI is over 30, consider them eligible for bariatric surgery, and if it's over 35, we would prioritize them to bariatric surgery. This is what the IDF is recommending if the A1C is not where you want it with standard medical therapy. Obviously, if the A1C is where you want it, you don't have to fuss with stuff like the bariatric surgery, but this is what the IDF is recommending. Now, in this country, it has not caught on. As I suspect if I were to poll the audience, how many are aware of the profound effects of bariatric surgery with management of diabetes? But it has caught on in other centers around the world, and it's slowly catching on here, and unfortunately, the insurance companies aren't buying into it at all. And they're the ones that are shooting themselves in the foot, because in the long term, you think of the cost savings if we've got a simple intervention that is going to result in amelioration of diabetes in 1 in 3 of those patients. It's coming. You know, and other payers from around the world, government payers from around the world, of course, have caught on to this a long time ago, and that's why we're seeing the numbers we're seeing. Most of the data I've shown here is actually European data. It's not that it's impossible, it can happen, but it's just slow to catch on in this country. And right now, you know, what am I to conclude with all of this is there's a very strong evidence and consensus for bariatric surgery as a mainstream option for treatment of type 2s in obese patients who are not well controlled with medications. And I think this is a safe statement, and I think this is where we're going to see diabetes going in the next few years as it slowly catches on in this country. Now, I leave you with the impression this is a be-all to end-all, but bear in mind that this needs to be done in centers that know what they're doing. It's not, because we've got a lot of places in the Phoenix area where people pop up and I'm going to be a bariatric surgeon. They come in, they get the surgery, the surgeon makes $1 million, off they go, and those folks don't do well afterwards because they're not followed over time with the appropriate support group. They gain the weight back and it's not going to help their diabetes. But as Jan points out, the ones that do well and centers that are able to follow them over the long term do well because they don't gain their weight back